This is Crystal Fenn with MedPage Today here in Atlanta at the American College of Cardiology meeting, where we've heard new results from the lipid and blood pressure sub-studies of the ACCORD trial. I'm here with Dr. Douglas Weaver of the Henry Ford Health System and past president of the American College of Cardiology, and Dr. Clyde Yancey of Baylor in Dallas and current president of the American Heart Association. So, doctors, what do you see as the real clinical takeaway message from these ACCORD studies?
Well, I might start. There's a couple of takeaways. This was a study looking at whether improving patients with diabetes lipids by adding fenofibrate to a statin would improve their outcome. We know that diabetics get heart disease, and that's why that patient population was chosen. And statins are recommended treatment for all of them. And so here the investigators looked at whether adding a combination agent, this time a fenofibrate, which has been around for quite a while, would make a difference. And it didn't make a difference. So that was message number one. Clyde, you might want to say what the other half of the study showed.
Well, the other part of the study focused on blood pressure. And I think that even though there are those that are wringing their hands and saying that this is going to be confusing, I actually think there's great clarity, and the clarity is in two areas. The first is that, without question, the usual care group did much better than expected. What that means is that taking good care of patients and being attuned to what they need works really well. And so we shouldn't think that the study was a negative trial or a failure. It really, like many other studies, demonstrated that when we focus and pay attention to correct disease management, patients do well. But the other message that comes out of all of the discussions we had today from both elements is that we really need to focus on prevention, both a priori prevention so that we don't develop diabetes, and then once diabetes is in place, to consider the preventive measures, i.e. lifestyle modifications that can make a difference. But I think that's the take home. Usual care is actually quite good, and prevention really is important.
Now, we saw that there were some subgroups where there was a suggestion of benefit of the more aggressive therapy. And in the primary results for the intensive glucose lowering results that were presented 2 years ago at the American Diabetes Association, there was a lot of talk about how this suggests that we need to be more attuned to individualized therapy, not just pushing hard on everyone. Do you see that as a message for cardiologists as well?
I think it's refreshing, actually, that we're not treating by the number, that we're treating according to the patient. And I know Doug, and I know he agrees completely with that.
And I think that we've learned that you can push too hard. You know, there isn't necessarily, more isn't necessarily better. And that's a message that we learned about diabetes control, as well as we've learned here with blood pressure control. And these patients did well getting them to what are our accepted goals already. And as Clyde mentioned, you know, the management of these patients has changed dramatically in the last 15 years after they have the disease. And so doing these extra things didn't make a huge difference. I think Clyde's comment about prevention and lifestyle modification, that's so tough. It's so easy to take a pill. And yet, we know, for instance, that the role of regular exercise will prevent diabetes, a huge reduction in the incidence of diabetes. And yet, to get people to regularly exercise, to get people to stay on a diet, is immensely hard. And to be honest, we have a lot of insight about what helps. But when you look at the overall effectiveness of our methods, they're not very effective today, are they?
Well, there are two extensions of that, though, Doug, and I agree with you entirely. The first is that, and Doug and I both have discussed this and are aware of this and are happy about it, in the last decade and a half, there really has been a striking reduction in deaths due to heart disease. And by best estimates, about half of that reduction has been from a very gradual embrace of lifestyle measures and preventive steps. So we know it works, but like Doug says, it's very hard to do. It's very hard to be consistent to stick with it. But imagine what could happen if we can really make that happen. But here's the real key consideration. everything that we're talking about right now, for everything we're mentioning, obesity is at the nexus. And if we can understand how it is we can best address obesity, being very novel, very provocative, very different, starting with children if necessary, and coming up with the right strategies to reduce the burden of obesity. That may have to implicate food policies, it may have to implicate incentives, disincentives, whatever it takes, but it's very clear that that's the nexus of this whole problem, obesity.
Mm-hmm. So sort of a back to basics approach, getting lifestyle measures involved here as well. There has been some concern raised at the session that patients may see these results presented in a negative light and be concerned about whether they should continue to be on some of these strategies that were used in the trial. Do you see that as being a concern as well? What should physicians be counseling patients who are concerned?
Well, I would tell patients always to ask your doctor, whether you should, whether these results, pertain to themselves. I wouldn't recommend that they interpret and change their medication regimen without going over it with their physician.
I agree with that, and I would also tell patients that the key word here is to be steady, because your doctor's ability to care for you is the most important thing in the equation. And if he or she really is committed to your diabetes care, that's really your best drug. Seriously, from all the information we've seen, that is the best approach. And so I would encourage patients to not panic. And then for the practitioners who are thinking about this, I would remind them that there were some signals that were pretty important. So for the group with the very low HDL and the very high triglycerides, maybe there's something there. We have to be careful of subgroup analyses. And then for the patients who had their blood pressure lowered, getting to 140/90, from higher than 140/90, terrific benefit in terms of reducing events, 50% less than what was anticipated. So there is rationale to be thoughtful and to be persistent and dedicated to lowering the blood pressure. And even in the group that had the lower blood pressures, the stroke rate went way down, but other markers did move nearly as well. So I'm not dismayed by what we've seen, but I think the key consideration goes back to the doctor's ability to care for the patient is paramount, and I would stick with the drill, stick with the drill.
Thank you, doctors. Here in Atlanta at the American College of Cardiology meeting, I'm Crystal Fend, MedPage Today.